gonna give this tonight, Jeff. I'm just gonna give it there. Oops, sorry. All right, I'm ready. Welcome. All right, good morning, everybody. Welcome to the Skills Day. So just a couple quick announcements. Today represents, again, another milestone for us. We spent a little time this year talking about how to use your stethoscope, how to do the heart and lungs, right, kind of what you should be looking for. And now we're going to talk a little bit about cranial nerves. And hopefully we had tried to make it a little interesting for you. So it won't be just a quote-unquote lecture. You'll be up and about, to do some things, and we have some what I think are interesting problems for you. All right, a couple quick announcements. So December 9th is the FEP Christmas party at Shingle Creek. Has anybody been there? Anybody ever? Kevin, do you recommend it or not?
Oh yeah.
Okay.
Good time.
Good time. Yeah, it's very nice. It's free. You and a guest are welcome. Food, music, all the EDs and us, EMS flight and PEDS transport. And last year we had a record attendance, 1,100 people. They had traffic jams from the exit to Shingle Creek all the way into Shingle Creek. Cones and cops, and this year we're going to have even more at it. So there's already all these things made out for traffic. So it's a pretty big party. We announced the EMS crew member of the year, flight crew member of the year, and PEDS crew member of the year. So we give out an award, a little plaque, and a nice gift card, and I announce your name. They do it for all the EDs and for us. So it's a nice time. Wednesday, December 6th, there was a drawing for Orlando Magic game. Everybody got 2 tickets, so we had 14 tickets. So hopefully, did anybody win? Nobody won. Okay, well, they're out there. I'll be there. And then December 20th, we have another 14 tickets for a Solar Bears game. It's a Wednesday night again. So, good teams socialize a lot out of work, even though it's hard and it's difficult to, especially this time of the year. Sometimes it's worth it just to be with other coworkers outside of the work environment. I'm not saying we don't do enough of it, but you can't do too much of it. So that's the idea behind all of this. We try to eliminate the money factor so you don't have to worry about who's paying for dinner or what it's going to cost you. There's no charge other than getting there and your time. So has anyone ever been to the sweet hockey game, basketball game?
Good.
Good?
Yeah. A lot of fun.
A lot of fun?
Yeah.
Okay, good. And that's what we're trying to promote. So we think it's a good idea for you to do that and to participate. All right? All right, so with that said, let's, this is, I don't know who it is. It can't be easy because they know I'm here, so I'm not going to worry about it. But, with that said, let's talk about the cranial nerve. So today, we're going to try to get everyone involved in what this lecture is not, just so you know. It's not about me standing up here and talking about the 12 cranial nerves and you rolling your eyes and saying, how many more slides are there? We're going to do one, and then we do the second one, and then we do the third one. By the 4th cranial nerve, you're all asleep, and, So we're going to talk about what I think are some practical applications. We'll just let these guys get settled, and then we'll get going with the lecture. So, you know what? We're going to get going with the lecture. Just you're in charge of getting your stuff. Okay. Okay. So here's why do we worry about the cranial nerve? What's the worry about the cranial nerves? So when you have a neurological change in a patient during route, what do you look for? What are you thinking about? What should you be doing? And that's what we're going to talk about. Now there's orientation. You can tell if they're alert and oriented. There's Gillespie Coma scale. There's some gait things you should check, some coordination, and a little bit about sensation. But for the most part, the cranial nerves will give you a lot of good information. So just bear with us here a little bit. Remember, your nervous system is very sophisticated. So if this is your brain, it's just a series of strings or ropes or synapses that go to every cell in your body and back, if you can believe it. Okay? So that the cranial nerves are sort of big nerves. There's a lot of them. So they're much thicker, and they innervate the head and the neck. And then there's a nerve that would go to your toe would be more like a piece of dental floss by the time it got down there. So the thickness is different. The innervation abnormalities you can see a lot easier with a thicker nerve than a tinier nerve, a smaller nerve, one cell nerve. So that's why we worry about the cranial nerve. And based on what the abnormality is, you can kind of predict what part of the brain is being affected. Okay, we're going to talk about whether it's deep in the brain or whether it's, how peripheral it is. Fair enough? Okay, so Steve Kurthy just walked in. Steve, how you doing, sir? And I can read Steve's mind. I know Steve a long time. Steve Kurthy is saying, this is going to be a boring lecture where Deponte is going to make us memorize all the cranial nerves. But I am not. You should not have to worry about memorizing. What you should be able to do is just take an exam, see that the cranial nerves apply, and kind of be cognizant of the abnormality. So let me sort of get to what I mean. So here we go. Does anybody watch this TV show Live PD? Anybody ever saw it? You know what I mean? So what do they do on that show all the time? Kevin, you see?
Well, it's from a central hub or whatever like that, but they monitor live PD stuff all over the United States.
Yeah, it's very interesting. Would you agree?
Yeah.
And you see a lot of drug drivers on there and field sobriety tests. Does anybody, so do you know the field sobriety test, what they do and what the point is of that? What are the police doing when they do this with their fingers?
They're trying to see if you're coordinated and can follow their commands.
Exactly.
Precisely.
Exactly. So the police officers are doing cranial nerve exams on their patients on the I-4, right? And they're seeing if they're intoxicated, field sobriety test. But this is exactly what they're looking for, just so you know. So they're looking for nice staggers. So they take your eyes and they say, follow my finger with your eyes, don't move your head, and they go to the left and to the right, right? Everybody ever saw that? And if they're really sophisticated, they make a big H. And they're looking for nystagmus, abnormal movements of the eye, involuntary contractions, because that represents an abnormality of 3 very specific cranial nerves that we're going to look at. And when you have nystagmus, in the context of worrying about intoxication, Molly, amphetamines, alcohol, that's something they use to sort of show intoxication. So that's what they're doing. The police officers who have Narcan in their pocket now also are checking for cranial nerves. So pretty slick, I would say. Would you agree? Does anybody know the blood alcohol level for the state of Florida? 0.08. Great. How many drinks is that, approximately? 2, probably a little bit more. 2, 3.5, depending on size and how far apart and what type of alcohol and all of that. But in general, it doesn't take too much for you to have a field sobriety test with nystagmus. So 0.04 to 0.08, you'll start to get nystagmus. Okay? So what those police officers are doing and what we should be doing is just this. So what we're going to do is look at how do we test these 3 cranial nerves that the police are doing right at the roadside, and in fact they're doing the right thing. So here's the 3 cranial nerves that relate to the eye. So 3, 4, and 6. Okay, do you need to know the names, where they exit from? No. So here's the oculomotor, the trochlear, and the abducens. But what I'd like you to know is how to look in the eyes and what the abnormalities are. So here goes. So the 3rd nerve, 4th nerve, and 6th nerve, these all control eye movements, whether your eye goes up or down or to the left or the right. There's 6 eye movements. So when your eye looks up, we call it elevation. Our job, to take care of our patients, is when you notice a change, is to look at these. And I think everybody looks in the eye, right? Everybody does it. And there's 2 ways you should do it. And if you just want to sort of pair up, again, have the patient and yourself look at each other and have them fixate on your nose. And then what you should do is go horizontally over to each eye, and you should watch their eye movements. Then go to the center of one eye, go up and down, then horizontal, up and down. And those are the 6 eye movements, and that's one thing that you should check. And you see that right on TV. So why don't you just do it to each other, just so you so here, Zach, you can look in your eye.
Go ahead.
What's this for?
You'll look at it.
Can I eat it now?
Yeah. Okay. Yep. All right. The other thing is, how do you check a pupil for, like, Paul, come on up. So here's what You guys have to bear with me here.
Be your guinea pig.
Yeah, I would just stand there and face the. So some things when you shine, you see everybody take a light and you do this and you make sure that pupils constrict. It's really not the way you should do it. And it's best, if you're going to do it, it's best to do it right the first time. So I'm going to put my hand on your face, okay? Sure. So there's my pen light, okay? I'm going to divide his face in half, and I'm going to just shine the light in. That pupil should constrict. This one should constrict also, okay? Then it's the same thing on this side. I would put my, okay? So I want to block the light from the other eye. Again, if a pupil does not constrict related to shining, you know you got a problem. Most likely it's 2, 3, and 5. Okay? So those are the things. Thank you, sir. Those are the things you want to look at. Make sense? So if you have a patient whose condition is starting to change, you need to know the name of those nerves. No, but you start with the eyes. Is that unreasonable? Absolutely not. So those are the things that you would look for. Fair enough? Okay. So while we're doing the eyes, let's continue on. And let's just go to 2. Okay, so 2 is the optic nerve, right? So the optic nerve is what's your ability to see. So people who have double vision, partial vision loss, problems seeing, fuzzy vision, those are the ones that this is likely the nerve. Okay? Now it also has the pupillary artery. Again, it forms the retina of the eye. How do you check for the retinas? How do you make sure that the retina or the optic nerve is intact? What are some ways we can do it right at the bedside? So one way is the Snellen chart, right? In the back of some books, you can see they have these little charts, little eye charts. You keep them 18 inches from somebody's nose. Close one eye, you check the vision. You close the other eye, you check the vision. And then you check both eyes. And that'll give you good information. Does everyone carry that? In general, no. Should you? It's hard to tell. But the idea is, in your care, remember, these are things that can help you. Patients who can't see, who can't speak, who can't smell, who can't hear, once that starts developing, something's not going right in the brain. One of the other ways you could do it, Paul, come on up again, sir. All right. I know, that's fine. Face the audience. What you want to do is think of his vision, field of vision. Close one eye. All right. And think of your vision of field just like this circle, and it's cut in 4 pieces like a big pizza. And what I would do is I would stand in front of him and I would say, look straight ahead, Paul, and let me know when you can see my finger. Okay. And then I would come over on this side and I'd do the same thing. And again, I would want those 2 lower visual fields to kind of be normal. If I took this one and I had it all the way up here, just say no. Can you see it? No. And that would get my attention. Would you agree? Now something's wrong with the optic nerve. The optic nerve connects right back to the front of the brain. There is a problem. So that's one thing you can do versus taking the 18 inches of the Snellen eye chart and doing it. You need to do that all the time. The ER, one of the things they're good about is testing vision. The other thing you need to know, okay, they do this. Again, they say, close one eye. Just look straight ahead. Let me know when it goes out. No, keep your eyes straight. Let me know when it goes out of your field of vision. Okay, good. Same thing on the other eye. You switch. Okay, same thing. Right. But if it was, so that would be an abnormality difference, right? This one's way over here. This one's close. So you would know if you think of this circle, one of those fields is not right. Again, the optic chiasm, which is where those nerves, cross, and which part of the retina is innervated. I'd say I would encourage you to read that and study it on your own. I think for us, what we need to know is if there's a neurologic change and the visual fields are changing. Again, that's a lot of very good information without knowing the nerve and that there's a little acronym Mount Suvius, right? How you can memorize the names of all of them. I don't think that's important. What I think is important is that you check the vision and you say, this is what I found. Okay, thank you, sir. Don't sit down for too long.
Okay, I'll be ready.
All right. And then the other thing that you should look for, so we just did 3, 4, 6, and we did cranial nerve 2, right? So we did 4 cranial nerves already. And Steve Kirthy said, I'm glad Deponte's not going in order, so we're not going in order. But does it make sense by thinking about all the ones that affect the eyes? I was hoping somebody would say yes. Come on.
Yes.
All right, good. So let's talk about the trigeminal nerve, and this is the corneal reflex. Again, another very characteristic, good, simple, easy test to see if there's anything wrong with not only the cranial nerve, but inside the brain. If you have someone's mental status or neurologic is changing, this gives you a lot of good information. And this is how you do it. Come on up, Paul. And I will not do it. So for the record, I am not touching his eye, and we are not officially doing it. This is just to make believe. When you look straight ahead, Paul, now without moving your head, look to your left. And then what I would do is I would come in with a piece of cotton, and I would nice and gently touch between the white and the iris part of his eye. Once I touched it, he should blink together, blink, and that's the positive test. That means the corneal reflex is intact. If one eye didn't blink, not blink one eye, then that would mean that there's a problem. Then you would do the same thing on the other eye. Right, Paul, move that way, sir. And face straight ahead. And again, just touch. They recommend cotton, just a little piece of cotton. It doesn't take much to touch your eye, and then you elicit the corneal reflex. That gives you a lot of good information. The center of the brain, what's happening? Is it full of blood? Is it full of a bullet? Are they intoxicated? So you know it's a good clinical sign. Okay. So the other thing, so why do we give you Q-tips? Are you going to do it on each other? Nope, you are not. Because I could just see the reviews on that. But this is what I want you to know. So the hospital, the ER, our ambulances, this room, are probably the most dirty, disgusting places you ever want to know. I don't care what anybody says. We have germs all over us right now. And this is a more civilized part of the hospital. You don't operate in those areas ever. Bottom line. So and they recommend cotton. Cotton is a good way to elicit the corneal reflex. So this is what I recommend. There's cotton tips. There's Q-tips that are sterile in a package, right? So once you open them up and you touch the Q-tip, to do this, then it's contaminated, correct? So you went from a sterile environment to a non-sterile environment. But this is what you can do. With clean hands, you can take the Q-tip from the sterile container, open it up, and then you pull off the tip. And now underneath it is the clean cotton, and you just touch it to the eye. So that's the idea of the Q-tip. How'd we do on that one, Steve? He was watching me, so I knew he was like, what's Deponte doing with this one? I could just see him back there. But not too bad, right? Okay, so that's what you would do. That's what I want you to think about. So think about all the cranial nerves and their names, not 100% necessary, but think about the things you want to look for. So eye movement, pupils, vision, and corneal reflex. And I think if someone's starting to have a neurologic problem, I think that those are very reasonable things. Do you need to say it's a third nerve palsy? No, but I think you need to know that the patient's right eye is now deviated or depressed down and laterally. Boy, that gives the neuro IC a lot of information. Nurses, Dr. Hellinger, whoever else is there when we get there. What I don't think we should do is be fighting with the ER and saying, hey, did you do the cranial nerves? This one's abnormal. You can, if you have a finding, absolutely bring it to everyone's attention. But the trick is be very cognizant of a patient who is in your care, who now has a change in mental status of some sort. Document these findings if you find them. Okay? Makes sense? All right. So we're going to continue on to two more things that I think you'll find very helpful. We're not going in order. There we go. So 9 and 10. There's two more cranial nerves. Okay, the glossopharyngeal nerve. All right. And what is this one? Anybody know? Any idea?
Which one?
Number 9. Okay, and number 10.
And then for swallowing?
Yeah, so 10 is very good. So 10 is gag reflex, and 9 for the most part we're going to say is the uvula. So now everybody looks in the mouth, right, and elicits a gag reflex. I just want to review exactly how we would want you to do it, which we think is proper. Okay. So the first thing, you'll see if you look in someone's mouth, again, drooling, facial droop is an ominous sign, right? So what do you want to do? You want to look in the mouth, look into the pharynx back here. You'll see the uvula here. See how it's pointed away? So a left stroke. So something in this part of the brain causes the uvula to deviate away from the stroke. So that's helpful information, right? Would you agree? So again, have someone just as best they can open their mouth. This uvula should be midline. We would all agree that that's pointing away from the stroke, right? So the irritable focus is here. Uvula is going to the right. Simple, takes 5 seconds to assess that, okay? The other thing I wanted to talk about a little bit is how do you elicit a gag reflex, okay? So, Paul, come on. We're not going to do it, don't worry. Well, I see this all the time, right? So we're going to check his gag. And what do they do? Say, ah, yeah. And I go, brrr, and I make scrambled eggs out of the back of his pharynx, right? That is not the way to elicit a gag reflex. This is going to be too hard not to. This is what we like you to do. Okay? Let's see, hard palate, soft palate. There's this line here, right? This muscle here. You can actually pull this away. What we'd like you to do is come in with a tongue depressor. Everybody use a Yankauer catheter. And we'd like you to put it here, right in this ridge here. We'd like you to go laterally. And that will elicit a gag reflex. Okay? So that's cranial nerve number 9. Forgive me, that light is killing. Then you would do it on the other side. So again, you would go laterally here at this ridge. You could have a gag reflex here and no gag reflex here. And that would again be a very ominous sign, likely representing some type of abnormality of the cranial nerve line. So just to think of your anatomy, the tongue is in the way, but your tonsil would be here, right? There's this line here. Everybody familiar with that anatomy when you look at it? What you don't want is what this guy's doing, sticking it right down to this. Who's not going to gag? The only patient who's not going to gag is a totally obtunded Glasgow Coma Scale 3. They're the only ones who will not gag, right? Other than that, it doesn't really help us then if we say they have a gag or not have a gag. You have to elicit it properly. So go down and press to the side. Go down and press to the side. Fair enough? It just says how to do it. Okay? And then here's the other thing that I wanted to show you is the 12th cranial nerve. So now that we're looking in the mouth, you also ask the patient how to stick out their tongue. Come on, Paul. So this is what everybody does. I think you're having a stroke. Stick out your tongue. This is the way you do it. This is how you ask them. You have them stick out their tongue. You ask them to move it to the right, to the left. Ask them to put their tongue back in their mouth, and then stick it out again. So, sir, stick out your tongue, go to the right, to the left, and put it back in your mouth. Good. And stick out your tongue. Okay. So that, again, the tongue points towards the side of the lesion. You can't say that. Try. So what we have is a tongue to the left, a uvula to the right, and no gag reflex on the right-hand side. Those are pretty good findings. Would you agree? Okay. So those are the things you want to look for. Again, have we memorized what cranial nerve and where they go? You'll get it eventually. You're in this business long enough. But what's important is you check those findings. So we've looked pretty extensively at the eyes and the mouth. Would you agree, Zach? This is pretty good information. Anybody agree this is not good information that you couldn't use? Okay? All right. Just a couple more. We'll do the accessory nerve, which is here. Again, this again controls the muscles of the trapezius muscles and the neck. So all you would ask them to do is shrug their shoulders up and down, right? And again, only one shoulder's going up. This means abnormality on the right, lesion likely on the left. Okay? And the other thing is the sternocleidomastoid muscles are controlled by it. You have them turn their head to one way, turn their head to the opposite. Wherever the weakness is, the lesion's on the other side. So other than the uvula, it's pretty good to say it's opposite, and I think that's all intuitive. Make sense? Everybody still with me?
Yep.
The first cranial nerve is
Olfactory.
olfactory. Very good. So how do you do this? Well, I'm going to see if you can get this one right. Here's a real test. So everybody does this. Smell. What do you smell?
Plastic.
Good. Very good. It's not the way you do it. What you want to do is occlude one nostril. I'm not going to occlude your nostrils. Very good. Smell. Good. Other side.
Pepper.
All right. So that's the olfactory. How long does that take? 10 seconds. You can use an alcohol pad, a chapstick in your pocket. You'll notice some of the residents, even in the ER, carry these thin little glass containers with a cork in them. You pull the cork off, and what does it have in there? Coffee. Coffee's very pungent, and that's like a standard to use. You'll notice them, they have them attached to their stethoscope. So you'll see that. The only other one, so we've done them all except for facial nerve. Did we miss any? We're going to go through them because you're going to get to do them all one time. Oh, and vestibular cochlear. I'm sorry. We have two more. Okay, so here's number 8. Vestibular cochlear apparatus, i.e. your ear. Remember, patients who can't hear, talk, speak, it gets their attention. Smell, that means there's abnormalities, right? Depending on what you're finding, depending on where the brain is. It's good information for us to assess. So how do you do hearing? Paul, come on, sorry. So there's 2 things we'd like you to do. In each ear, so I wouldn't do it, but I would say, because there's always, no matter where you are, it's very noisy. Like sometimes you try to listen to heart sounds in an ambulance or an ER. I don't know about you, but it's very, very difficult at times. So you want to kind of funnel into the ear. I'm going to talk directly into your ear, and I would say the number 7. Can you hear me?
Yes.
Okay, good. And I would go 37. Can you hear me?
Yes.
And I would do each ear. So that's a gross, good test where you're like, if you couldn't hear 37 out of the right versus the left, remember, opposite side is the lead. Those are things that you can do. It's simple, takes 2 seconds. Just for completeness, I'll show you the 2 tests. You know what this is? There's really 2 of these, but just for expediency. So these are certain decibels that you should be able to hear. What happens is you want to initiate these, you want to put them on the mastoid bone here, so you can't hear it anymore. Then once you can't hear it anymore here, you put it next to their ear, and that controls all parts of that vestibular cochlear nerve. And you do it on both sides, both ears. And then the other thing you would do is put it right here in the middle of your forehead, and you should be able to hear it pretty good out of both ears. So that's another. Are you going to carry these around? Are you ever going to carry one of these around, Paul?
I have it in my pocket.
All right, good. So why don't you just show everyone so we can go right on to the mastoid?
What do you want?
Yeah, just
No. What is it?
yeah. Right here. And then once you get, but you can only hold this part of it or else. So you got it. Can you hear it? So let us know when you can't hear it. No. Keep it there so you can't hear it. Say what? Now, put it right here. Can you hear it? Oh, that's good. You can't hold these. You can't hold these. You have to be holding like this. So anyway, you put it here. And you couldn't hear it. You double check here. Fair enough? Okay, one more. Put it right in the middle of your hands. Holding the fork. So. You know, can you hear on both sides? Is it pretty clear? What can you hear? Pass it around. Let everybody try it. We'll continue on. So that's the vestibular cochlear. Okay? Make sense? And then the last one is the facial nerve. And I did want to spend a little time talking about this one. This is the 7th nerve. Here's a very very common one that I think you need to be a little bit careful of and cognizant of. And this is called the seventh cranial lobe, and that's the one that controls really the muscles of the face and neck. Okay. Sometimes it's not uncommon for patients to wake up and they can't close their eye, they can't drink a bottle of water because they're drooling, they have numbness on their face, and sometimes their hearing is impaired, sometimes their neck is weak on that side, and they say, I'm having an acute stroke. Or we notice it and we say they're having an acute stroke also. The trick here is, though, it's not so much the nerves. So that's why I brought this rope, because those are the ones that exit the brain, the center of the brain, and symptoms without actually, 3, 4, 6, trochlear 7 or 5 or 2. That's not important. What's important is think about the findings in the eyes, think about the findings in the mouth, the tongue, the uvula. You have ear, you have olfactory, and then you have facial. This is easy, the accessory nerve, right, and the sternocleidomastoid. Also on this stuff, the forehead is important. Again, show your teeth is important, and also have the patients blow out their cheeks like. So if you couldn't do that, again, get your attention. But remember, it's the periphery, it's the branches of the facial nerve, not directly. And that's something you have to be careful. Okay. How do we do, Steve? Did you learn anything?
Yeah, sure.
You're learning that Paul can't hear out of his left ear. That's what I learned. Any questions?
This is from Steve.
I don't want to. All right. You guys are good? No questions?